So my name is Monica Thakar. I'm a pediatric bone marrow transplant physician at Fred Hutch at Seattle Children's. Um, I um, and I had the privilege of working on this paper with my colleagues, talking about our experience with the Primary Immune Deficiency Treatment Consortium, which is a group of centers in both the United States and Canada that have come together who have a focus and expertise on primary immune deficiencies of all sorts, severe combined immunodeficiency being one of them, and really trying to improve outcomes for children and infants with SCID. So we developed a natural history study. And with that natural history study, we were able to collect over 3 decades of data on infants and children who were diagnosed with SCID in both the United States and Canada who were referred to one of the PIDTC centers. At the time of this report, there were 34 PIDTC sites that were participating in this study. Since then, we've increased the number of centers that are part of the PIDTC, but there were 34 that are part of this particular study. And so what we wanted to do is summarize kind of what the data looked like for allogeneic hematopoietic cell transplantation, looking at all of those decades. And what's really unique about this data set, because other groups also have data sets that look at severe combined immunodeficiency as well as other primary immune deficiencies. But what's really unique about our data set is because we were able to initiate universal newborn screening in the United States, and it's in many provinces in Canada. It's hopefully going to be universal there pretty soon. We had a pretty nice framework of years prior to the initiation of newborn screening, and then the uptick of newborn screening over approximately 8 years after. And so we were able to kind of have this line in the sand of before newborn screening and after newborn screening. And just to kind of look at outcomes, we had this strong suspicion, and our hypothesis was that newborn screening would improve outcomes, but no one has ever actually really shown that newborn screening improves survival after transplant. And so we were hopeful that that's what we would show. And so we looked at all of the years prior to newborn screening that we were able to collect all of this data. And this data, I have to say, one of the things that I'd like to highlight is the group effort and the hard work of many centers, both smaller centers as well as larger centers that take care of this very rare set of diseases, how they were able to come together and really provide some very detailed data that we were luckily able to analyze. And it really would not have been possible to even have this data set without all of the centers' participation. So I definitely wanted to highlight that. But what we found is really from our first year of the study, through, the 28 years that we looked up until 2010, that overall survival after allogeneic transplantation was really stagnant. It was around 70%, specifically around 72 to 73%. And this is despite decades of improvement. So we've had improvements in supportive care, antibiotics, recognition of SCID, more centers having the skill set to transplant this disease, where we've seen really remarkable improvements in survival. But for SCID, it's been really a fairly straight line. And so when we started implementing newborn screening, which initially started with the first pilot studies happening in Wisconsin, but easily spread to other states, including California, New York, and now is available in all 50 states in the United States. We were able to look at those infants that were presenting to medical care based on having a positive newborn screening and compare those to children not only of the prior years, but also since 2010, looking at those who present with just a clinical diagnosis. So in states, for example, that didn't quite yet have newborn screening, versus those who presented to medical care due to family history, because because it's a genetic disease, many of the kids present to medical attention because it's known that SCID is in the family. And so they go to medical attention very soon after birth. Sometimes even in utero, they're able to do sampling to identify these infants. And so they're able to go right to medical care early. And so what we were able to see is we saw a statistically significant, so not just statistically significant, but a huge clinical improvement in survival of over 90% in those children who came to attention based on newborn screening. So specifically, it was 92.5%, but well into the 90 percentile range. And so we did some more detailed analyses based on very diligent work by our biostatistician, Brent Logan, who really helped us look at this data and really interrogate our clinical questions in a very statistically elegant manner that allowed us to identify it was the early age of going to transplant and going to transplant with minimal to no infections that really promoted this improved overall survival. And the thing to note is that going to transplant early and going without infections happened throughout all time points of the study, but it was more likely to happen after newborn screening, and that's really what made the difference. So it's newborn screening as an entity leading to early age, less than 3.5 months of age, and freedom from infections that really promoted this improved survival. So, it's really difficult with population-based newborn screening programs to show data like this because you'll never have a control group. So once newborn screening is established as a public health policy, you'll never not have a group of kids who didn't have newborn screening, really, unless the family declines it at birth. So it's a very tiny population. So there's really no control group. And so the way the study was developed and based on our hypothesis, this is really the best way to be able to show the improvement of survival based on an intervention like newborn screening.
Well, I would also say, I think Monica maybe wasn't surprised when she saw that nothing changed for decades and decades. And then all of a sudden in the most recent decade, the survival for SCID jumped up. But actually, all of our colleagues in oncology saw a very, very different thing, which is steady improvement in survival year by year by year. And so there was every reason to think that with the transplant medicine improving and other medical improvements, that would happen for SCID too. And so actually I was quite surprised. I think a lot of us were surprised when instead of a steady sort of slow improvement, we saw this stagnation and then the jump. So that's really what was exciting about this paper, and it pointed directly to newborn screening. And I guess comparing to Pompe disease, I would say, every state in the United States has its own screening program and adopts diseases with its own criteria. Of course, the RUSP is a thumb on the scale and helps encourage states to adopt screening, but they don't do it all at the same time. And so actually this could be a lesson for the Pompe community to look at the patients who were picked up by newborn screening as opposed to patients in other states that did not yet have newborn screening and see if they can show a difference. And if they cannot, then I think they've got a problem, because we showed that when you've got a good newborn screening test, you actually do see pronounced differences.